Welcome back to Diabetic Foot Files. I'm Dr. G, and today we're going to talk about the big what ifs. So, I don't know if anybody watches Love Island. I'm a big Love Island person, Love Island and House of Dragons. And yeah, last night's episode, absolutely not. The big what if. What if Amaya picked Carl? He should have picked Carl, okay? Because Casey talked about her like a dog. But or what is it, Sheep Stealer from House of Dragons? What happened if that girl didn't fly him? Just let him, she didn't know how to train him, right? But in medicine, I mean, they say don't live with what ifs, right? But I'm a big preventative person. Prevention is better than cure, right? So imagine if we had a time machine, not one that takes you back to dinosaurs or ancient Egypt. I know a lot of people, if they made mistakes, they want to think about a time machine, but one that takes you back about 6 months before, let's say, a patient loses their toe, or 1 year before a patient underwent a below the knee amputation. If you can stand beside them at that moment, seeing what would be in the future, right? What would you tell them? Which decisions would you change? What warning signs did everybody miss? And today we're going to step into that time machine. So, welcome to Back to the Future, right? And we're going to bring this thing called the Preventability Index, okay? And this is not about assigning blame, it's not about, anything bad, but about uncovering the opportunities that were missed to prevent an ulceration and to help save a limb, okay? So, we already know every amputation has a story, but not every amputation could be prevented, but many could. Okay. Just like one of the doctors said, just because a leg could be saved doesn't mean it should be, right? So sometimes the difference between keeping a leg or losing one isn't about a miracle surgery. It's about a phone call or removing a shoe. That's another thing. A lot of patients don't remove their shoes during doctor visits. And I understand that, but if it's a general doctor's visit, we still need to see your feet, right? Ordering X-ray, checking the patient's pulse. And today, like I said, it's not about blaming anyone, but asking the question, what if? What if they saw the wound earlier? What if vascular was referred to the patient earlier enough to recognize? What if the infection was taken more seriously? What if the patient had known the warning signs? Perhaps, that's the question. So, the Preventability Index, this is a framework designed to encourage systematic reflection that factors in what contributed to a diabetic ulcer progression or to major tissue loss and that can result in amputation. It's intended to improve quality as well as an educational tool, okay? But it's not a validated clinical predictive model, okay? So limb salvage, I see diabetic foot ulcers as the butterfly effect, okay? Once you hear the patient's whole history, you can think in your mind, this is where certain steps were broken that made the situation worse, okay? Because no diabetic ulcer just develops overnight. It's usually a blister that just pops open, right? Or a wound, puncture wound, things like that, okay? But major amputations often result from many small events occurring over weeks or months. And think of each decision as a domino. One missed appointment, don't ever miss your doctor's appointment. One ignored blister, one delayed vascular referral, one ill parent fitting shoe, one untreated ulcer, a fever that goes unnoticed, maybe something insignificant, but all together, it can become something very quite catastrophic. And limb salvage is the science of this, of interrupting the domino effect of this, disaster. So, with the Preventability Index, we ask this question: if we could replay the patient's journey, at what point could we have overcome something that could have changed the trajectory where this patient could avoid amputation or save their limb? So when we think about a time machine, let's rewind back like 12 months before the ulcer, right? Could the patient diabetes have been controlled? Were there annual foot examinations? Did the patient have appropriate shoes? Did they know how to inspect their feet? 6 months before, was neuropathy diagnosed? Were there calluses building? Was there structural deformities like bunions or hematomas? Could offloading and orthotics could have prevented the skin breakdown? 3 months before, was there a blister? Did the patient continue walking on it? Did someone miss something as or dismiss something as just a sore? 1 month before, was there infection brewing? Was there ischemia present but unrecognized? Did they delay seeing the physician? Now, 1 week before the hospitalization, could earlier debridement prevented this progression? Would vascular evaluation would have helped? Should advanced imaging have been ordered earlier? So, the domino effect, and like I say, they always say don't live life with what ifs, right? But sometimes we have to because, like, what if the neuropathy was diagnosed 5 years earlier, right? What if the patient had taken off their shoes at the doctor's visit? Many ulcers are quite hidden. A lot of patients don't know when there's an ulcer because they have neuropathy. So at a primary care visit, they could have an ulcer brewing and they just have their shoes on, or their cardiology visit, or their dialysis visit, or their endocrinology visit. And a lot of times people do forget to examine the feet. And, we have to discuss and recognize the importance of opportunistic foot checks whenever we have the chance. If the 2 feet are there, please take off your shoes and socks. A lot of patients like to take off just one shoe of the area of the problem. I need you to take off both shoes and socks. And you know what? It's good to see. It's good to know, okay? Even if it's like, oh, I haven't washed my feet in a while, or there's flakes from the socks. Don't worry about it. This is a doctor's office. We're supposed to treat these things, right? What if somebody checks the pulses? We have to figure out if there is PAD, collateral circulation, toe pressures, all the vascular interventions that's needed, right? And what if the infection was recognized, like, let's say, even 48 hours sooner? Cellulitis, abscess, fascial spread, septic arthritis, osteomyelitis, necrosis, or even Charcot, many patients are treated for sprain, cellulitis, and gout, but what about acute Charcot neuropathy, okay? About the need for immobilization and offloading, baseline x-rays, things like that, okay? So here comes the preventability index score. It's, to answer a question in the structured or repeatable way, it turns a messy clinical timeline into a numerical risk narrative of avoidable limb loss. And like I said, it's not to assign blame, but to help us identify the system failure points early enough to change the outcome for the next patient. Okay. So in the preventability index score that we created, I created 0 to 100, right? So interpretation, a score from 80 to 100 is highly preventable. So this is means that there is an early intervention window open. Score from 50 to 79, that means it's partially preventable. That means intervention was delayed or occurred, like delayed intervention occurred. And a score from 20 to 49, that means there's low preventability. That means there is advanced disease established already. And 0 to 19, that means it's non-preventable at that stage of presentation. This is a limb-threatening, salvage limited situation. And for the scores, we have 5 different domains. Each domain is scored from 0 to 20. So the higher the score, the more preventable it is. The earlier the stage, the more reversible disease, things like that. And the lower the score, the more advanced the pathology. So 1, structural deformity, it has 0 to 20, okay? Each one is like 0 to 20. So let's say the patient has a hallux valgus, right? Abductor valgus, a hammertoe, right? Or Charcot foot. We 20 Score 20 is no deformity. Score 15 is mild deformity of mild flexible deformity. Score 10 is moderate deformity. Score 5 is rigid deformity present. And score 0 is like collapsed deformity, just like a full flat foot collapse or a Charcot rocker bottom foot. The deformity, the rigid the structural deformity is there. Next is skin integrity. It has a score from 0 to 20. So 20 is intact skin, 15 is callus only, 10 is fissure and blister, 5 is superficial ulcer, 0 is a deep ulcer with tissue loss. This is our first biological failure point. Next is infection burden domain. So if Also, the score is from 0 to 20. So 20 is no infection. So the higher the number, remember, the less likely there is infection, or that's the perfect one, 20, okay? So 20 is no infection, 15 is superficial infection, 10 is cellulitis, 5 is abscess or deep infection, and 0 is osteomyelitis, a systemic spread. So infection dramatically reduces salvage potential. You have to remember that. 4 is a major domain, the vascular reserve domain. So 20 is normal perfusion, 15 is mild PAD, 10 is moderate ischemia, 5 is critical limb ischemia, and 0 is gangrene present. And 5 is time to intervene. Okay, this is a very important one. So 20 is the patient was seen within 0 to 2 weeks of the first sign of problem. 15 is 2 to 6 weeks delay, because 'cause you'll have patients like, "How long have you had this wound?" They'll be like, "I don't know, maybe about 6 weeks," you know, and because they won't remember, but they're like, "Oh, but I remember I stepped on something a few weeks ago." Few weeks ago, that's not 1 week ago, okay? 10, score 10 is 6 to 12 weeks delay. 5 is greater than 12 weeks delay, that actually happens to us, and 0 is a chronic neglected presentation, wound presentation, okay? And like I said, for the scores, you have to add them all up. 80 to 100 is highly preventable, 50 to 79 is partially preventable, 20 to 49 is low preventability, and 0 to 19 is non-preventable at the stage of presentation. So let me do a quick example, okay? Because bunions, okay? Like a patient having an ulcer on the medial aspect of the first MTBJ, let's say on the right foot, bunion, right? Secondary to a bunion original structural deformity, and it could result in a toe amputation. So the deformity is going to be a 10. The skin integrity is going to be 5 because there's an ulcer already present. Infection, if there's signs of infection, purulence, cellulitis, 10. Vascular, if it's palpable pulses, or if the patient has mild PAD, I would say 15. And then time delay, let's say the patient waited, let's say about more than 3 weeks, time delay is gonna be like a 10. So you add that all up, it comes to 50, that's partially preventable, okay? Let's do a one metatarsalgia, something simple. Callus stage identified early. So the structural deformity is going to be 15. The skin is going to be 15. The infection is a 20. So there's no signs of infection because it's just a callus, the superficial callus. Vascular pulse is palpable, great perfusion, and time delay. The patient came in the moment they saw a callus, right? So their preventability index score is going to be 90 because it's highly preventable. So we do debridement and offloading because we can help prevent the ulcer entirely. That's another thing. I always try to make patients understand this. Uh, Callus is just a baby ulcer, in my opinion. Everybody has their identity, but it's a big warning sign because the longer the callus stays there, the more the skin breaks down underneath it. Okay. And like I said, not every amputation is preventable, but many are at least. And if we can replay the patient's journey, we know which points could have prevented that patient having an ulceration in the first point. Okay. So, I mean, the index score is kind of helpful, but it's all about asking how many opportunities existed before the patient came with this outcome. Okay. And this is beyond a blame game. It's never a blame game. Okay. It's about, that's the whole point of why I even started this, because I wouldn't say annoyed, but I guess, flustered, and I thought it was cruel that there were patients getting lied to and not being told the severity of it, and not understanding the severity of it, and not understanding the severity of their diabetes, but they had actual primary care physicians or doctors or even been seen at the ER and been discharged. And the fact of the matter is, I know that the doctors knew that this was wrong. I knew, like, okay, if you know how to grocery shop, right? You know when something's expired, when something's not. You know when you're picking out fruit, you know if it's like not a firm, ripe fruit, and you know when it's getting rotten. So I'm saying these were not subtle signs that I was seeing when patients were getting discharged by healthcare professionals. These were blatant signs, like I said, not just erythematous. big swollen foot, draining wounds, mild odorous. It wasn't a joke. It wasn't a joke. It was on I kept on saying it was kind of like on the borderline of inhumane cruelty to discharge somebody like this in this state of being of their entire foot and almost septic and just saying it's okay because the patient has neuropathy and can't feel it as bad, because the patient's not fully aware because you didn't educate them well enough about the severity of it. And then just at the end of it, you just say, we have to cut off your leg. And the patient's wondering, how did I get this far? A patient who is educated about what's going on with their diabetes, they're very diligent, in my opinion, because every patient I've dealt with, they're so diligent in their care. They want to be diligent. They're like, oh, well, the doctor said this. And you know something I noticed also with my patients? They watch how you dress the wound. So if they have to miss appointment, let's say for financial reasons, transportation reasons, they're like, "Oh, I remember how you dressed it, doc. You did like this, or you did like that, and you used this." The patients one thing I know about my patients or patients that I've treated, they know your routine. They know what you use to cleanse the wound. They know what you did to dress the wound. They like the doctor did this. They wrap it 3 times because when I hear my patients talk about it and they've been in a situation where they have to do it again, they're like, "Oh, the doc did this," and I'm very proud of y'all. I'm very, very, very proud of you because they watch what they do, and they also watch if you just don't care and you just slap on a dressing on there. But you know it's not thing to take lightly. A diabetic ulcer, diabetes in general is nothing to take lightly, and I hate the fact that some patients weren't told or aware of the severity of how bad things can come. They just told them, "We gotta cut off your leg," and they don't know how they got like this. They don't know, okay? It's the barriers of knowledge is power, okay? The purpose is to improve quality of improvement and educate the patient. It's not to assign fault, We have to build a culture of prevention and care and empathy, okay? We have to remove the cruelty and inhumane aspects that has been seeping its way into the healthcare system. Unfortunately, a lot of people have been cruel and not empathetic and treating people in a just in a humane manner. I don't know why. I get it, moral injury, I get it, burnout, I get it. But still we have to try our best to advocate for your patients. I want my patients to advocate for themselves and say, hey, I know that something's wrong with my foot. I see it, it's red and swollen. This is something wrong. Can I get a second opinion if you're trying to just get me out? Things like that, okay? So, I hope people liked it. It was just a quick episode, just to remember that every ulcer has its own timeline. Prevention opportunities occur multiple times before hospitalization. Small interventions, especially early, can often prevent major surgeries later. And not every amputation is preventable, but every case can teach us something from it. Okay. So I hope the Preventability Index can help people with a framework for learning, improving the care, and strengthening the limb preservation efforts. And this is Dr. G, and this is Diabetic Foot Files. I'm sorry, it's the weekend. Life, Love Island yesterday really got to me. Amaya, you should have picked Carl, okay? Can't get over that. And I am excited for Game of Thrones for Sunday. We're ready for season episode 2. We're ready for episode 2, okay? So, yeah, I'm Dr. G. This is Cyber Files, and take care of your feet because they take care of you.